Hey, so just a heads up, this episode talks a lot about addiction, mental health, and institutional trauma. There are some great ideas in here for how we can do better, but to be honest, this episode is a little less on the hopeful side and touches on some sensitive topics. So if you're cool with that, please stick around because it's a great conversation. Addiction is something of a dirty word in our culture. My guest today is an addiction counselor, and she says she isn't afraid of that word, addiction. But in general, the way our society treats people struggling with addiction is really dehumanizing. As a culture, we have this idea that addiction is the result of some kind of moral failure, as if people have just given into temptation or don't know how to make better choices, and that's the end of the story. Of course, that's totally inaccurate, but it is a common story. We have a culture of fear around drugs and addiction, and there are a lot of factors leading into that, which I won't go into here. But what I do want to talk about is how that culture informs larger structures. The mental health and criminal justice systems, policymaking, all the ways our society organizes and provides care for things like substance abuse. Right now, the welfare system in the US, but also a lot of other places, is really punitive. The red tape involved in ensuring that resources are only granted to people who deserve them, whatever that means, creates a lot of extra work for both care providers and patients. But more importantly, it sets up a bureaucratic maze that's hard to navigate, meaning a lot of people slip through the cracks or otherwise don't get the care that they need. A big part of this is a lack of resources, but it also has to do with how we distribute those resources. There's a history in this country of extreme moralizing and hand-wringing around welfare and other publicly funded programs. The fear is that public assistance means people won't work, families won't hold together, taxpayer dollars will go to waste on people who don't even want to get better. When conservative fears about minorities and the poor come together with the neoliberal drive to minimize publicly funded social programs, it's not a matter of what would actually materially improve people's lives. It's about ensuring that the mythology of American capitalism, market fundamentalism, the nuclear family, individual responsibility and work ethic can continue unchallenged. This partnership between conservative moralizing and neoliberal policy is not only decoupled from reality, but actively harmful and counterproductive. In their book, The New Way of the World, Dardot and Laval argue that the turn towards neoliberal policy is not a, quote, straightforward retreat of the state, but rather its political redeployment on new bases with new methods and objectives, end quote. This isn't just a return to market fundamentalism. We need to recognize the, quote, disciplinary character of the new neoliberal policy, according government the role of vigilant guardian of legal, monetary, and behavioral rules, assigning it the official function of supervisor and forming individuals who are adapted to market logics, end quote. That means controlling people indirectly through incentive structures rather than directly via mandates, prohibitions, or any sort of universal program. Sure, we're free to choose in a very limited technical sense, but our choices are strongly shaped by where positive and negative incentives lie. I think it's also really important to understand that these incentives are rarely distributed equally. In the case of mental health care programs for low-income and other vulnerable groups, there are a lot of negative incentives and not many positive ones. In his book, The Happiness Industry, William Davies writes, quote, "Wherever the economics of mental health become more explicit, the gap between care and punishment tends to shrink." In 2007, the economist Richard Laird laid out the business case for cognitive behavioral therapy, or CBT, demonstrating that it could save the UK government money, given the treatment's brevity and apparent success rate in keeping people at work. But with the dawning of austerity, the government announced that disability benefit claimants could have their payments stopped if they refused to attend CBT. People would effectively be forced to receive a talking cure. Quite how therapy could be expected to work when it was only being undergone under the threat of losing 85 pounds a week was not explained, end quote. It's not that neoliberal policy doesn't recognize that people need care. Rather, it becomes the responsibility of individuals and families to solve their issues through private means rather than through state programs. But the prevalence of addiction, especially among vulnerable and marginalized groups, should be a sign that there's something wrong with how care is provided, not with people's individual choices or morality. The problem is systemic, and so our solutions must be too. My guest today is Sarah, an addiction counselor at a nonprofit agency in California. Sarah's agency offers a wide range of services, primarily to clients who have Medi-Cal, which is California's publicly funded health insurance for qualifying low-income individuals.
Right now, my primary job is I manage the women's intensive outpatient treatment. So that's 9 hours of counseling services a week, about 8 hours of group counseling and 1 hour of individual counseling. I also am a grant project manager, meaning I help to apply for different sources of funding to provide services to clients. As I mentioned earlier, like the agency I work for is primarily funded by Medi-Cal, and Medi-Cal does not provide a very expansive funding package. It's certainly, it's very restrictive and kind of keeps us from being able to offer a larger expanse of treatment modalities to clients, unless we're also constantly cultivating other funding sources. So that might come from federal grants, state grants. And so that is kind of my secondary full-time job, is applying for those funding sources, managing the projects to roll out these services for the clients, making sure the money gets used in the way that it's intended and that it's effective for the clients, and then also designing outcome measures and reporting back outcome measures so that we can continually justify these revenue streams. That's kind of the reality to working in nonprofit.
Mm-hmm. You're sort of beholden to the funding sources. You have to prove that it's the money's going where it should.
Absolutely. Constantly.
What does that look like?
It looks like having a whole host of people whose literal full-time jobs are to collect those outcomes, report back those outcomes, deal with auditors, deal with compliance. And for me, I'd say my job is about 50-50. And that's normal in nonprofits. Like you hear all the time working in nonprofits that people wear a lot of hats. I mean, I think my email signature has like 3 different titles in it at this point, like not even kidding.
So what's the typical demographic of the clients you see?
So the typical treatment demographic that I work with is going to be pretty low income clients. As I mentioned before, we primarily see Medi-Cal clients. And although the agency is not limited to Medi-Cal clients, typically what you see is it's rare to have agencies that integrate a lot of both Medi-Cal clients and private pay insurance.
Why does that happen?
That's a difficult thing to answer, because most agencies, when they decide like, hey, we're going to start accepting drug Medi-Cal, they have this vision that they're going to serve both. You know, we're going to serve like the low income clients that are relying on publicly funded insurance, and we're also going to serve the people who have Anthem or, you know, Blue Cross, whatever. And it's generally what I have heard just among colleagues is the populations don't mesh, and there's also a certain amount of stigma once you do have Medi-Cal clients coming in, because a huge portion of those clients are going to be homeless, involved with the criminal justice system. A lot of them might be kind of coping with really like long-term unmanaged mental health and present in ways that are overwhelming or off-putting for kind of the typical clients you'll see coming in with private pay. I think another issue is that the needs are different when you're comparing a client who is, homeless, unemployed, relying on publicly funded healthcare and like financial assistance with a client who has like employer provided healthcare. Mm-hmm. They have a completely different set of issues they're coming into treatment with. So for the former client, they're going to be concerned with things like finding housing, finding a job, like just getting back on their feet. And the services are going to tend towards that case management, that tend towards kind of like crisis management. Whereas people who are coming in with like employer provided health insurance, they typically are going to be kind of focused on a different set of issues.
So I'm just assuming that there are some differences in addiction treatment for the Medi-Cal group and for the private pay group.
Absolutely. I mean, even just in the number of agencies available. I mean, I'm working in a pretty large county, and my agency is the only detox facility in the entire county that accepts Medi-Cal. There are 16 Medi-Cal funded detox beds available.
I'm guessing that's not nearly enough.
No, it's absolutely not enough.
So what happens? Where do they go? Where do they wind up?
The hospital.
Got it.
Yeah.
And
And that's for acute detox services. So detox is typically, roughly 5 days to like 2 weeks. And that's it. Like 16 beds. And if you're in really intense like withdrawal, you go to the ER other than that. But there's no other residential facilities. And typically the hospital is not going to admit you to like manage your whole withdrawal period. They might like admit you to get you through like an acute seizure or heart palpitations, and then discharge you maybe with like medications to try and help you like get through the period until like you can get into residential care. But yeah, services can be pretty scarce. I'll say the other really big disparity when you're talking about Medi-Cal clients is the availability of mental health care. Substance use treatment is far more available to Medi-Cal clients than standard like mental health services. It's next to impossible to connect a Medi-Cal client with a therapist. You can call the Medi-Cal office and expect waits of like 6 to 9 months to get paired with a therapist.
And that's just because the therapists aren't taking Medi-Cal, most of them?
Oh, that's a big part. Most of the care management for Medi-Cal is extremely demanding. That's something that my agency has to help our licensed therapists with, is getting approved to be able to accept Medi-Cal clients. And typically it takes about at least 6 months.
Wow.
And the paperwork is like 1.5 inches thick.
So that's not something that the therapist could do themselves if they wanted to.
Oh, I have no idea how anyone would. I mean, I have a coworker, and her full-time job is compliance, and that's a big part of what she does, is she helps the clinicians to get the certifications that they need. But it's so in demand that she even takes like contracting work independently to help therapists get approved.
Why is there so much? Why are there so many hoops to jump through there?
It's taxpayer-funded money. The amount of red tape that comes with that is just, it's obscene. It's absolutely obscene.
Now that we're talking about compliance, it got me thinking about the flip side of compliance. So not only do providers have to be in compliance with the protocols, but patients are expected to be compliant. And that's not always easy, especially, if they don't have housing, if they don't have a job or a way to commute.
Absolutely. In compliance, it's kind of this like looming concept over everything, right? Mm-hmm. And it's incredibly difficult when you're talking about addiction treatment, because the nature of addiction is that the behavioral symptoms make it to where it is incredibly difficult for people to comply with any sort of like regular prescription, be that, times that they need to show up for groups, or medications that they need to take, or check-ins with, a worker or a therapist or whatever else.
So, I mean, is it really a problem of compliance? Is it really that they just can't comply with their treatment? Or, it's not so much a personal choice to not comply. It's like the system is failing them.
It is, and it does. And I will say that, there are some positives to drug Medi-Cal, and one of those is that the drug Medi-Cal, the statewide drug Medi-Cal organized delivery system is premised upon ASAM, so the American Society for Addiction Medications format for addiction treatment. And at least that sets kind of like a strong conceptual premise for understanding addiction and understanding that issues with compliance and steady commitment to treatment are part of the process.
Okay.
So when it comes to compliance, I feel like the treatment providers themselves are actually pretty good about allowing space, like always being ready for clients to leave treatment and re-enter treatment, always being ready to meet clients like where they're at in their kind of personal stage of change. And then, like, you know, the trick to addiction counseling is you have to try and find where clients do have sincere buy-in and work from there. But where things get sticky is all the other entities that inject compliance into treatment.
Right, because they want to know that, again, like they want to know their funding is going where it's supposed to.
Well, and particularly when people are mandated to treatment, because like I said, like as a treatment provider, we can deal with non-compliance. There are times where I'll have to discharge clients just because they're consistently not showing up, or they're not, you know, like we can't get their treatment plan done. I'm sorry, you can't stay in treatment if we can't get a treatment plan done. But that's okay. We work with it. You know, like you can discharge and come back as many times as you need to. It's like, I'm ready for it. But then when you have clients who are court ordered to treatment, or it's, you know, it's part of their probation, or it's part of their CPS case to get their children back, things get a lot more sticky. You don't have the space to be discharged from treatment like that without severe consequences.
So what do you do in that situation if you're working with a client who just doesn't want to be there, or maybe they want to be there but only because it's the only way to see their kid again or something?
It's really tough. It's something that challenges me, like ethically as a clinician, because I care so much about ongoing informed consent. I have to like truly acknowledge that the work that I'm doing is non-consensual. And that's something that is difficult for me to carry, like as a clinician, because I really, really believe that clients deserve to have fully free, informed consent about whether or not they want to continue participating in this, because it's arduous. Treatment is arduous. Healing from addiction is one of the most challenging, difficult, painful things you can possibly do. And then the unfortunate reality is, like, a lot of my clients are forced to be there under threat of losing their children or under threat of going back into jail.
I can't imagine they show up excited and ready to talk to you and work through it.
No, no, they show up resentful. You know, they show up feeling really unfairly treated in a lot of cases. A lot of cases that's true. The way that I try and approach it is by acknowledging it. I try to not do the thing that counselors do sometimes where they're like, oh, well, on the bright side, this is a great opportunity for you. You know, people don't want to hear that. I think it's better to acknowledge to someone straight to their face, like, I understand that you were being forced to be here by a social worker or by a probation officer. What can we do while you're here to try and deliver like something meaningful to you? You're being forced to be here. There are forces outside of your control that are coercing you to participate in this treatment. And as long as you're here, let's try and collaborate on figuring out, you know, what we can provide to you that will actually be meaningful or will actually help you move closer towards like the goals that you sincerely do have for yourself.
Yeah. I think that's something that gets overlooked a lot when we talk about, you know, a therapeutic or a counseling relationship. There are a lot of mental health care situations where there is a very serious imbalance of power happening.
Very serious. I really dislike working under this threat of compliance from outside agencies. It's something that I navigate as skillfully as I can when I have clients who, you know, have a PO they have to report back to, or a CPS social worker they have to report back to. Those are probably the two most common. But absolutely, like I hate having to report back that someone isn't being compliant with their treatment, knowing that that's going to have like severe implications for their case. Yeah. And again, like consent under these conditions is really fraught with complications, because substance use treatment information is very highly protected with an additional set of protections like on top of kind of normal HIPAA guidelines. And so anyone that I release information to, like a PO or a CPS worker, a client will have to sign a release of information for that to happen. And technically they could not. I'm not going to make them sign it. But if they choose to not sign that release of information form, their PO or their CPS worker is just going to interpret that as noncompliance.
It really seems like a very punitive system. And the way that a lot of people come into contact with mental health care, if it's not through an organization like yours, it might be through the prison system or something.
Absolutely. A ton of my clients are people who have basically been raised in incarceration.
Can we just talk about the diagnosis of substance use disorder? Where did that come from, and how is that diagnosis used? What do you have to do to get there, to get that diagnosis? And how that interacts with like the services and treatment that's available.
So I'll start by saying that the DSM is the standard of diagnostic legitimacy for every single service that is provided. I would say that in terms of the clinical utility of DSM diagnoses for substance use disorders, it's not huge. It's not huge. In fact, those diagnoses are given with relatively little consideration.
What do you mean?
People are diagnosed on day one. And although it usually is it has to be either a physician or a licensed clinician that does that diagnosis. Typically, especially in nonprofit agencies where staffing is so limited, it's going to be, I guess, kind of paraclinicians who are actually interviewing clients. So people who are, if not certified drug and alcohol counselors, they're like registered technicians that are doing all like the intake assessments and collecting all this information, and then they package it all up, and then a physician or a licensed clinician will read down it and put a DSM diagnosis.
So they don't even have time to meet the person that they're diagnosing.
No, I would say about 95% of the time, the person who signs off on the diagnosis does not ever meet face-to-face with the client. In addiction treatment, at least in my experience working for like a nonprofit context. The other thing with the way that the DSM treats addictive disorders is the way that the DSM defines substance use disorders is actually very simplistic. So the first piece of the diagnosis is going to be, what substance is it? Are we talking alcohol use disorder? Are we talking opioid use disorder? Are we talking stimulant use disorder? Boom. The second kind of dimension of that diagnosis is going to be the severity level. And it's pretty simple because there are just 11 criteria that the DSM lists, and it's the same for every substance. It's the general criteria for substance use disorder are things like cravings, giving up activities that are important to you, having physical or psychological problems associated with your use. And the way you score severity is literally just how many of those criteria show up. How many of those criteria does the client say yes to? So if it's 2 or 3, it's mild. If it's 4 or 5, it's moderate. If it's 6 or more, it's a severe substance use disorder. And the way that this happens is literally, like I said, that kind of paraclinician level person interviewing a client and going down this list and telling a client, say yes if you've had any of these: withdrawals, tolerance, using substances in larger amounts. And they check the box.
Just rapid fire, like as soon as they walk in the door.
Yeah. And I will say for that reason, substance use diagnosis, like giving what is considered to be a legitimate DSM diagnosis for a substance use, it's pretty easy. It's pretty simple, right? It's a lot less complex, I think, than a lot of mental health disorders. They have kind of more complex diagnostic criteria with longer spans that those symptoms have to present. In substance use treatment, it's relatively straightforward. So
do you think that diagnosis is a good way of of framing the problem, of understanding what issues a person is presenting with and how to treat them?
To be honest, the diagnosis tells you what substance they're using.
Got it.
And the majority of clients, too, that I see are going to be scoring at moderate or severe as well, just by virtue of like the particular substances they're using. So someone using heroin is pretty much always going to experience things like tolerance, cravings, withdrawals. So it's almost like kind of by definition.
It seems weird to me that those criteria apply to every drug the same.
Yeah.
Why are you using the DSM diagnosis? What's the purpose of diagnosing people when they come in the door?
Billing.
It's
billing.
Back to the compliance.
Yeah, to be perfectly honest with you, I think that's kind of the primary function of the diagnoses. It doesn't guide treatment so much as it guides billing. Like someone's chart has to have a DSM code in it.
Something we touched on earlier is that people will often enter and leave treatment.
Mm-hmm.
So this initial diagnostic process is happening over and over again. So do they just wind up with like an ongoing list of like all these diagnoses?
Oh yeah, absolutely. You'll open like some client, because there's an electronic health record, and there are people with 2-3 dozen different behavioral health diagnoses, both addiction related and kind of general mental health. Oh, another thing I wanted to say is like when we have part of the problem is we don't have an integrated behavioral health model. We have separate addiction treatment and then mental health. And so when you have people coming into addiction treatment agencies with sincere mental health disorders, that addiction treatment agency generally is not equipped to diagnose that co-occurring mental health disorder. So typically it'll look like a longer process of like referring them to see a psychiatrist. And if you're talking, again, Medi-Cal funded psychiatry, that's like a 6 to 9 month wait time.
So a lot of juggling.
And for a lot of clients, typically the only way they come into contact with mental health care is through crisis services. Short-term, like involuntary psychiatric holds or the ER potentially. And again, like any behavioral health service that is provided requires a diagnosis to be billed for. And so as a result, you have these people that are showing up in like mental health crisis management services repeatedly, getting diagnosed with whatever. So I will regularly open charts and see clients who have 2-3 dozen different diagnoses, and it'll be things like unspecified mood disorder, unspecified psychotic disorder.
What do you do when you see that?
So as a service provider, in a lot of cases, it doesn't tell me that much, especially because when I'm working in addiction treatment, these are often people who have been dealing with chronic substance use for years and years and years. And you can't, let me use meth, I think, as the primary example. So in the example of a client who has been coping with methamphetamine use disorder for a couple decades, and that has landed them in involuntary psychiatric holds a dozen or more times throughout their life. In general, it is said that you can't make a differential diagnosis between methamphetamine-induced psychosis and other forms of psychotic disorders for a minimum of 4 months, because someone in methamphetamine-induced psychosis presents pretty much identically to someone who has a diagnosis of schizophrenia. So you have all these people that are stacking diagnoses of schizoaffective disorder, unspecified psychotic disorder, bipolar with psychotic features, like all these different disorders. And the reality is, like, they have not been off of methamphetamine long enough to determine that at all.
And nobody's seen them for 4 months.
No one is seeing these people for 4 months. No one is getting a 4-month stay in psychiatric care. It's almost impossible to even get into residential mental health facilities, period.
So this list of diagnoses doesn't really, it's mostly for billing. It doesn't really inform the sort of treatment that you offer or that they need.
It can inform me, insofar as telling me that a client might need more mental health case management. But typically, no. The diagnoses that a client comes in with from short-term psychiatric holds don't tell you a lot about what that client will present with and what that client will be dealing with once they're off of drugs for a few weeks or a few months. And it's very, very dramatic. That's something I don't think people realize, is how intense drug-induced forms of psychosis can be. And also that they can resolve very dramatically, very fast. I mean, there are persisting symptoms, of course, and it can take months for that to clear, but you can watch someone go from being completely dissociated from reality, like completely gripped by delusional, hypervigilant, paranoid thinking, just flight of ideas, not able to communicate coherently to other people, and then 6 weeks later, presenting as a completely different person almost. It's pretty incredible.
So it sounds like if we did have if the care was integrated where they were able to access mental health services and substance abuse services together, or be evaluated for like which one they needed first, we'd be in a much better position to understand what they need.
I think so. And you hear integrated behavioral health as kind of a buzzword a lot these days. And I think that is something in general that providers are trying to move towards, but it's slow. But I really believe that in a lot of ways, the separation of addiction treatment and mental health treatment is a pretty arbitrary delineation, right? Like,
yeah,
these two things interact.
They co-occur a lot.
They co-occur so much. And the way that they interact in a single human being is just, it's a very like pervasive, holistic kind of entanglement, the way that I see it. You can't really separate the two. And the discussion of, which service does someone need to receive first is one that comes up constantly in clinical work. And it impacts people's care all the time, because you'll hear conversations about like, oh, this person needs to stabilize their mental health before, they can attend addiction treatment, or they need to get off of meth before they can attend mental health treatment at this mental health hospital. And how much does that really make sense to have those services sequential?
That's a good point. There's almost a better understanding that could be gained from looking at both at once, because it is that it's integrated within the person.
Yeah. And I think something else that's worth acknowledging is that mental health symptoms can express more dramatically as someone gets off of a substance, because in a lot of times that substance was fulfilling the role of helping them to like manage or suppress those symptoms. And as they come off of that drug, you can see these really dramatic expressions, particularly to trauma-related symptoms. So that's the thing, is in general, I think our model needs to be more integrated and more ready to respond, because as someone gets off of a substance, you can expect both dramatic extinguishing of psychiatric symptoms, like in the case of amphetamine-induced psychosis, but you can also expect dramatic expressions of mental health symptoms that were kind of dormant before then.
Right. If you're not prepared for whatever happens, that they're not really escaping that cycle of getting juggled around. I do want to touch on substance abuse and stigma. It's unique as like a very stigmatized, even criminalized diagnosis. That's something that I know you've mentioned before, and I'd love to discuss that more.
Yeah, absolutely. I mean, the stigma of addiction is so powerful in our society. And there are some very ugly realities to addiction. There are forms of suffering that you witness as an addiction counselor that are really difficult to look at in the face. And I think as a society, we have a really visceral negative reaction towards things like IV use of substances, the way that impacts the user physically. And I think part of why the stigma of addiction is so powerful in our society is because the kinds of PSAs and education that we have received have leveraged the ugly realities of addiction as a scare tactic.
It's like the scared straight thing.
the scared straight thing. And so there's been almost like this cultural hyperfixation on these physical markers of addiction, things like track marks, things like, losing your teeth.
I remember the posters of like what it does to the skin on your face, like from my nurse's office at high school.
Mm-hmm. And I think that's part of what makes the stigma of addiction so powerful, is because unlike a lot of other disorders, it tends to show up with these very dramatic physical markers.
Right. And those markers don't inherently have to be demonized, but we do demonize them. It becomes this like scary, monstrous thing.
Yeah. Dehumanizing.
How does that affect the people who get that diagnosis? Like, I'm imagining there's a lot of like maybe shame or denial, not wanting to acknowledge that you're this thing that society's been telling you to hate.
Mm-hmm. Absolutely. I think it definitely plays a role into why denial is a huge barrier to be kind of addressed early on in addiction treatment. No one wants to be an addict. An addict is one of the most kind of dehumanized labels to have in our society. And that label is going to drastically impact a person's experience with every single institution they come into contact with. It just inherently changes the dynamic, whether you're interacting with the criminal justice system, the medical care system, the mental health care system. All of those things are going to be hugely impacted by the stigma of addiction if that's something that you are carrying.
How does that manifest? Is it sort of like they're perceived as like untrustworthy?
Mm-hmm. Perceived as untrustworthy. And also, I think there's a tendency to ascribe the reason for all of their problems, like to the addiction.
Oh, interesting.
So like you're a poor person because you're an addict.
It's like placing individual blame.
Yeah, addiction becomes a frighteningly convenient way to place the blame for someone's, what's the right way to say this? Once someone has been labeled as an addict, all of the suffering that impacts their life from myriad different dimensions of life can all be boiled down to the fault of the addiction. And in general, I've not found that to be the case. I mean, the clients I work with have some of the most traumatic life stories you could ever imagine from early childhood, and have been just like systemically let down by institutions their entire life. Like the number of clients I have where you can see, in their record, the very first legal case in their record is the case of their parents versus the county, where they were removed from their family of origin for whatever reason, followed by, years of involvement in juvenile incarceration, juvenile psychiatric care, and then just a lifetime of involvement with the criminal justice system and other institutions. And it's really shocking, too, like how much criminal justice involvement and involvement in psychiatric institutions co-occur. Stigma also has a really powerful impact on the way that people perceive themselves.
It has a very strong moral dimension.
Yeah, and it can decimate people's self-worth. Like once you've kind of bought into the conception of yourself as being an addict, it can be really hard for people to appreciate their inherent worth as a human being, especially when they're so constantly faced with reinforcement of that idea with the way that they're treated by medical providers, police officers, social workers, all these different authority figures who are telling them, you're a bad person and you're failing because you're a drug addict. That kind of becomes the self-narrative.
Yeah, you internalize that.
Yeah, and they anticipate that from everyone they engage with, which is really sad. And so for me, I mean, one of the most rewarding aspects of my work is being able to not do that.
Yeah.
Like being able to show up as even just one human being in this system that isn't going to respond to them in that way is really rewarding for me. especially because I particularly work with pregnant drug addicts, which are possibly the most stigmatized population. People have a real visceral reaction to that, right? Like the thought of someone using while pregnant. How could you do that? How could you do that to your child? And that stigma is so powerful that even other people in active drug addiction will shame and ostracize pregnant people who are using.
Wow.
And you see that pretty surprisingly commonly, actually. Like people who are literally still in their active addiction being like, how could you do that? Like, you need to get clean. And that is a population that I think people feel really comfortable stigmatizing, the pregnant drug addict. And they don't realize that I think people hold on to this fiction that if you're pregnant, somehow that makes it easier to get off of drugs because you have like that additional motivation. But I have found that the opposite is true because pregnancy is a massive stressor on every aspect of your existence. Your mental health, your physical health, your socioeconomic realities. Pregnancy is a massive stressor for anyone. And when you add that massive stress on top of the stress of being addicted to a substance and trying to get into recovery and going through the arduous, challenging process of detoxing and getting through that early period and being asked to, evaluate and reconstruct your entire life. Pregnancy doesn't make that easier. Pregnancy makes that magnitudes more difficult.
Yeah.
And I don't think I've met a single client who was ignorant to the realities of what using while pregnant does to the fetus. And that's something that causes them a significant amount of pain and distress and grief and guilt.
I mean, they need support in that moment, not blame.
Yeah.
So, I mean, you already talked a little bit about how you want to be the one person in the system who's not perpetuating that stigma. I'm curious to hear your ideas for expanding that sort of care. How can every treatment, every institution that patients come into contact with actually do them right? And that's big, and you definitely don't have to answer all of it. But I'm sure you have some ideas for how things could be better.
Yeah. And you know what? I think that the field of addiction treatment actually has some particular wisdoms that behavioral health at large can benefit from. And I think it's unfortunate that a lot of the times people regard addiction treatment as being kind of like a lower level of care or a less sophisticated level of care than general mental health services. When in fact, I think that the field of addiction treatment has generated some really valuable insight on how to work with some of the issues that tend to be really exaggerated in addiction, things like stigma, things like issues of coercion in treatment, because it's so common for people to be court mandated to addiction treatment, things like how a counselor can embrace ambivalence and kind of dance with ambivalence rather than labeling it as a client being difficult or resistant. And I think that as we work towards an integrated behavioral health model, that addiction treatment professionals do deserve kind of a more respected role where their input is more welcomed. It's interesting to me that people who are licensed to provide mental health services are by default also licensed to provide addiction treatment services, and the inverse is not true. I think that the field of addiction treatment and the specialists that work in it have a lot to offer in terms of insight to the larger field of behavioral health. Addiction counselors are very, very gifted in a lot of ways at being able to just offer really radical, unconditional positive regard, which is something you see in mental health therapy, right? But in addiction treatment, that is central.
So unconditional positive regard, can you break that down a little bit?
Yeah. Unconditional positive regard is a concept from humanistic psychology, which it posits that a clinician first and foremost needs to be able to demonstrate to their client that I regard you as a human being who is full of worth and positive characteristics and value, regardless of anything else. So regardless of whether you comply with my treatment recommendations, regardless of whether you relapse and continue to use, regardless of your criminal justice history, regardless of the symptomatic behaviors that you present that might be, sincerely problematic, I still am able to identify and respect your inherent worth as a human being, and I have positive regard for you. And that can be really hard with addiction, because the truth about addiction is, like I said, it has ugly realities. So as much as I'm sitting here saying, we need to treat people with respect, we need to not stigmatize people, the other reality you learn working in the field of addiction treatment is that addictions do make people behave in some horrific ways, unfortunately. And a lot of times in the field, we refer to that as symptomatic behavior, things like lying, stealing, harming other people. That's a reality of the disorder. And so it takes a really radical level of unconditional positive regard to be able to meet someone in the fullness of that reality, acknowledging that, hey, your disorder has made you behave in some genuinely harmful ways. And I still recognize you as a human being.
Right. So they come into contact with a lot of people, like parole officers or CPS officials, who I imagine aren't doing that sort of unconditional positive regard. Yeah.
No, they're not.
Do you see room for those other professions to also take on this idea?
Yeah, I think those other professions also, in general, need to be better educated about the realities of addiction. I think we're so quick to moralize behaviors that might be better understood as symptomatic behaviors rather than evidence of, poor moral quality or a character flaw. Because I'll say even the most morally upstanding person in the world is probably going to be capable of lying and stealing when they're in full-blown heroin withdrawals.
Mm-hmm.
And if you think you wouldn't, most people do until they're in that situation, I think.
Are there any other takeaways from addiction treatment that you hope will spread, that you hope either other mental health professionals or just people in general can put into practice?
I think awareness of trauma is kind of the next stage. We do strive to be trauma-informed, but I think that with both addiction treatment and general mental health, everyone needs to cultivate a more expansive understanding of the way that trauma manifests in people. Because we know that PTSD and addiction co-occur, and we kind of understand the mechanism to that. Personally, I think that trauma is much more expansive and pervasive than people realize. And I think that a lot of trainings that I've been to about trauma-informed care talk about trauma as being it's triggered or it's not. It's on or it's off. It's like a light switch. And, your role is just to understand whether or not that light switch is on or off. I think the truth about trauma is that it's better understood as kind of like a constant undercurrent for someone who is coping with a sincere history of lifetime trauma. It's kind of like an ever-present electrical current that keeps the nervous system in a state of quasi hyperarousal always. And what that does is it colors all of someone's cognitions, the way they see the world entirely. So I think that trauma is in some ways more subtle than people realize, but also more pervasive.
It seems like something we could all benefit from, to make an effort to see people as people, regardless of symptoms, regardless of symptomatic behavior and the scary PSAs that we saw in the nurse's office growing up.
Yeah. And I think to move away from the hyperfixation we have on compliance and start recognizing the ways in which trauma makes it difficult, if not impossible, for people to comply with treatment recommendations.
Yeah, it's sort of just become a general, commonly accepted principle that people have to deserve treatment. That moral aspect is really pervasive.
Yeah. And something I think people don't appreciate too when it comes to people with addictive disorders like not wanting to volunteer for treatment is that these people have massive institutional traumas most of the time. When you're talking about people who have grown up in the foster care system, in different forms of incarceration, unfortunately, addiction treatment reproduces these institutional environments, especially when you're talking about residential treatment, where typically like you don't have access to a phone, you have scheduled meal times, you have people, forcing you to comply with all kinds of rules that are necessary in that context, but still triggering. And that's something I've noticed in addiction treatment as well, that this dynamic evolves where the clinical staff become like correctional officers, and clients respond to them in the ways that they have developed from other institutional traumas for responding to authority figures. So when we try and say like, oh, well, addicts need to just get clean, they need to just go to treatment, I think it's worth it to be aware of how much institutional traumas might play a role into that reluctance.
It's like we're buying into the policing. We're policing ourselves when we do that.
And I've had clients with just horrific experiences in their youth with both incarceration and with psychiatric care. So it makes sense to me that, that they really struggle to participate in a highly structured treatment program without having all this trauma come back up.
Yeah. Our trauma-informed care needs to include institutional trauma.
Yeah. And I don't think we appreciate the role of institutional trauma enough yet.
It's a really great point.
I will say, so for the positives, one of my motivations as a clinician is I have a lot of conviction in my belief that the people who are most abandoned by society, the people who are presenting, with severe drug addictions, with severe mental health symptoms, are absolutely capable of transformative healing when they're provided with the right services. I've witnessed it happen, and it's incredible. And that's something that the last 3 years of experience working in addiction treatment have taught me, is that even the people that you might consider irredeemable or beyond help are absolutely capable of just like incredible transformative healing. And I think that there are a lot of initiatives to move towards the type of care that people need. I think one shift that I've noticed is that conventional addiction treatment is very heavily biased towards cognitive behavioral therapy, which is mainly focused on, really exhaustive listing of irrational thought patterns and confronting those, really exhaustive listing of triggers and plans for coping with those. And there's a benefit to that. But I think what we're also realizing as we see how much addiction is intertwined with things like trauma is that there is a need to go deeper than cognitive behavioral therapy, because we know that trauma lives beneath the cognitive mind. It lives in our bodies. It's deeply encoded into like our emotional memory. And so we do see that addiction treatment agencies are starting to adopt new modalities that are more trauma focused, things like EMDR, things that are more mindfulness focused, like dialectical behavioral therapy. And we're seeing results. And I think that this shift is kind of in its early phases, but there is funding out there available. There are grant initiatives at state and federal levels, and we are seeing these really hardworking clinicians at these publicly funded agencies doing everything in their power to implement like pilot programs to show people like, hey, if we make cutting edge clinical modalities available to our homeless, unemployed Medi-Cal clients, they're capable of recovery too.
That is really great to hear. Like, finding a treatment that works seems like it would be the harder thing, and expanding existing treatments that we know have that transformative effect, that's really just a matter of wanting to do that and making it happen.
Yeah, because we have all these modalities, and unfortunately I think that the populations that stand to benefit the most from them have the least access. And we see that changing now through the hard work of these clinicians and administrators in these kinds of like publicly funded nonprofit agencies that are just working themselves to the bones to figure out how do we make these services available to people, and how do we produce outcome measures to start proving that this is worthwhile.
Yeah, if they all care as much as you do, I think we're in good hands.
Yeah. And there's a lot of people who really, really do care. And I think that that's, progress in these fields is slow, but it is so committed, and there's so much conviction in the people who choose to work in these fields that I do trust that we're on an important forward path. And I think that to answer the question of, what do we need to do in addiction treatment to address the needs of people more effectively, I think it's that we need therapeutic interventions that address the wholeness of the human being. Addiction is not kind of this like insular phenomenon like that occurs inside of a human being that you can just specifically prescribe and diagnose and treat that without addressing all the entanglements throughout that individual human being. And I think the other area that really needs to move towards improvement is just the amount of social support we have available to people. One of the struggles I find with addiction is when we ask someone to stop using, you are asking them to undertake a tremendous task. Like, you are asking them to unravel their primary coping mechanism that they have for navigating life. You're asking them to tear their house down to the foundations and rebuild it. And what's the reward for doing that? Really, like that's tough. Like, we want people to heal, but then the reality is they do everything we ask, and then they're still struggling in this system that is just overwhelmingly oppressive. Like I said, I work with mothers primarily. Most of them are single mothers, and it's just unreasonable what we demand of single mothers in this society, that they should be able to raise children single-handedly and provide for a house and work full-time and have a car and go to school. And I think that that's part of the larger systemic issue with addiction treatment is we have not crafted a society that offers enough of a meaningful reward for pursuing recovery.
So not just providing support during, but knowing that there is support at the other end.
Absolutely. And that people are able to find meaningful lives. In DBT, there's the concept of, you're trying to create a life that is worth living. You're not just healing pathology. You're trying to help people pursue a life that is worth it to them. Another concept from DBT that I think is really important is that we reinforce support in times of wellness as well as we do in times of suffering. And this is a really interesting concept to me, is that so many of our systems are structured to where once you pass a certain threshold of doing well, we retract all the help. And you could even say Medi-Cal, right? Like you're fully covered by public insurance until you cross a certain income threshold, and then you lose all those benefits. And so the DBT concept of reinforcing wellness is acknowledging that in the way of a lot of our systems work, which is that we only offer help and we only offer support and care in times of need, and then withdraw it when people start to do well, we unconsciously reinforce sickness because it unconsciously teaches people that the only time they receive care is when they're doing poorly. With recovery, addiction recovery, that's a really big problem, is that people have all this support, right, in residential treatment and for the 3 to 6 months around the time where they decide to get clean, and then they're kind of just left floating. So I think just kind of more robust, long-term supportive systems are part of what we need as well.
My last question is, what does utopia look like to you?
I think I would say that I would like to see everyone have access to the support they need to build a meaningful life. And I like to think about that term meaningful, that's in many ways for me a better measurement of life than happiness. So I would like to see a society that's more supportive of people pursuing a meaningful existence. And I think that also means access to therapeutic modalities that encompass the fullness of the human experience. I think the kind of medicalized model of focusing on pathology is not particularly effective. And I think that the people who are suffering the most, like the Medi-Cal clients I work with, who are, typically impoverished, often homeless, underserved by virtually every single system, are the people who stand the most to gain. I would like to see more humanity within the kind of behavioral health apparatuses that we have. They're very depersonalized. They're very, very bureaucratic. And the way I kind of understand my role as a clinician within these apparatuses is to kind of try to cultivate oases of humanity. Mm-hmm. Because I find myself in situations where I'm very much a cog in the machine. Like I have a project I'm working on right now to start doing a treatment group inside of a jail with a literal captive audience. And I've kind of had a lot of ethical turmoil internally about that. And kind of what I've arrived at is acknowledging the clients that I'll be seeing in that jail are not there. They're not participating consensually. However, this is also an opportunity to try and cultivate an authentic human experience within this very constrictive system. And if I can do that for those people so that they walk out of that room at the end of a group session and feel like that experience was meaningful or valuable to them, then I've done the best I can within the constraints of that system.
Perfect. Thank you so much.
Yeah, thank you.
The anthropologist David Graeber wrote a lot about care and caregiving as central aspects of our economy. What would it look like if the economy was organized around care? If instead of just looking at how dollars move around, we look at how care moves around, how much we produce and how it's distributed? Obviously, teachers, nurses, daycare workers, they're all directly involved in the work of caring for other people. But as Graeber points out, a person building a bridge is ultimately doing it because they care about people being able to cross a river. A person who makes cars cares about people having transportation. And after the car is made, that's not the extent of the labor that'll be put into it. It has to be washed, tuned up, and kept in working condition. Graeber argues most work isn't raw manufacturing, but the maintenance of things. And that's not to mention the importance of unpaid care work in the home, rearing children, household chores, and so on, that turns out to be central to the functioning of our economy. That's a really important development in economic theory, and it's why the family maintains a central role in neoliberal philosophy. None of the traditional objects of economic interest, markets, the GDP, competition, and so on, could exist without care being present every step of the way. Caring for others is how we've gotten this far as a species, regardless of what shape our economies took. How can we really open up the possibilities of care, making sure everyone gets the radical compassion they deserve? Not by working to earn it, but just by being human beings of inherent beauty and worth. Now, this is no economic policy proposal we could put into action tomorrow. But it's an important piece so often missing from our conversations about the economy, about healthcare, about equality and well-being. Let's really think about care, what it means, where it comes from, how we can maximize its potential. Let's think about extending it to natural resources or to our planet, our original caregiver. Let's develop these insights further through rigorous study across disciplines. And let's build a more caring future. The weight of the world is love. Under the burden of solitude, under the burden of dissatisfaction, the weight we carry is love. Who can deny? In dreams it touches the body, in thought constructs a miracle, in imagination anguishes till born inhuman, looks out of the heart, burning with purity. For the burden of life is love. But we carry the weight wearily, and so must rest in the arms of love at last, must rest in the arms of love. Solarpunk Now is written, hosted, and produced by me, Luca Dowell. The poem was an excerpt from Song by Allen Ginsberg. The Solarpunk theme song is by Red Keener on SoundCloud, with additional music by Gabriel Rivas. You can follow the show on Twitter at SolarpunkCast, or visit solarpunkcast.net for all episodes, including show notes. You can also visit solarpunkcast.net to leave a donation in my tip jar. I don't run ads, so your support is greatly appreciated. That's solarpunkcast.net, link in the description. And remember, the realization of any vision requires action. I strongly encourage you to get involved with local organizations whose goals align with the brighter future you want to see. Analysis is important, but we have to back it up with practice. Keep dreaming big, and keep up the good work.